Tēnā koutou katoa, and welcome to the third of three sessions of the Health Committee for this week. So today we've got with us Sir Professor David Skegg and Nikki Turner from the Strategic COVID-19 Public Health Advisory Group. So welcome Professor Skegg and Dr. Turner. Lovely to have you with us. So what I thought I'd do is just hand over to you briefly to introduce yourselves and also the work of the committee, and then we'll just open up for questions. And I understand we have up to 90 minutes with you today if we need it. So handing over to you, Professor Skegg, and thank you for coming on board.
Thank you very much, Madam Chair. The group that I'm chairing has 6 members, and our terms of reference state that the purpose of the group is to provide independent advice on the ongoing COVID-19 response, informed by expertise in epidemiology, infectious diseases, public health and modelling. I would stress that we are an independent group. The Ministry of Health don't sit in on our meetings, and our written reports go to ministers without them seeing a draft. It's very common with these sort of committees that you put in a draft for people to suggest corrections and so on, but the reports that the public have now seen are exactly what we submitted, and they weren't seen by seen by the ministry or by ministers in advance. And we were given an assurance that our reports would all be made public. We had our first meeting on the 23rd of April, so we've only been going for 4 months so far. And you'll have seen our written reports, and I've also briefed ministers verbally on quite a number of occasions. I'd like to introduce my colleague, Dr. Nikki Turner, who is also on the advisory group. Dr. Turner is an expert on immunisation, so I'll be referring questions about vaccines and the vaccination rollout to her. She's also in general practice, so she brings the perspective of primary health care and indeed of the health system generally. I think it's important to remind members that there are other advisory groups, including the one chaired by Sir Brian Roche, which has an even longer name than our one. In fact, I always have to look it up. It's called the, somewhere here I've got it, yes, the COVID-19 Independent Continuous Review, Improvement and Advice Group. And they are the folk who have been monitoring activities such as the contact tracing, and the MIQ facilities. So they would be the best people to comment on the management of the current outbreak. Obviously, we're happy to talk in general terms about that, but we're not directly involved in the management of the current outbreak. You'll have seen that our main role so far has to be to advise on the overall strategy in New Zealand and also on plans for reopening our borders once the vaccination rollout is completed. You'll also have seen that we've concluded that the elimination strategy is the best option at this stage of the pandemic. We've been careful to define what elimination means and doesn't mean, and we've also emphasised that this strategy needs to be reviewed regularly, and we're sure it will be reviewed before the start of next year when we can consider reopening our borders. I think the last thing I'd just say is obviously at the moment, our number one priority is to stamp out the outbreak that we're currently experiencing. And the other vital priority is to vaccinate as many New Zealanders as possible in the next months ahead. Thank you.
Okay, thank you, Professor Skegg. Just wondering whether you'd like to say a few words briefly, Nikki, before we open up for questions?
I think David said most of it, thanks. I'm here to support and take questions, and I particularly have extensive background in vaccinology and in primary care. So just happy to roll into questions, I think.
Wonderful, thank you. Okay, so first question across to Chris Bishop, and then after that, Debbie Nawera-Packer.
Always helpful to unmute the microphone. Sorry about that. Thank you, Professor, and thank you, Dr. Turner. And can I suppose, on behalf of the committee and New Zealand, extend our thanks to you for all your hard work on this expert group.
Thank you.
Which is providing enormous value to the country. So thank you very much for that. We've got quite a bit of time with you, but there's quite a lot to get through. I suppose where I'd like to start is in relation to paragraph 7 of your last letter to Dr. Verrill around reconnecting to the world, which has been made public, but it's got some relevance to the current outbreak as well. So in paragraph 7 of the letter, you talk about basically the problems of returning travellers being required to quarantine at home, and you talk about what we did last year when that was required basically for a while, and you said they didn't do so consistently. Measures to check on their adherence turned out to be largely ineffective. You basically recommend that on a trial basis for reconnecting to the world, but it's come up again in the last day or so in the context of the minister saying that one option for quarantine as a result of the latest outbreak is that people may have to return to home self-isolation. I just wonder if you had any views or comments on whether or not that would be an efficacious or sensible thing to do in light of what you've previously said around the problems last year.
Do you mean home self-isolation of people who are testing positive in this outbreak?
Yeah.
Yeah. Well, clearly it would be a second best. The ideal situation is for people not to have to isolate with other members of their household. That's true with COVID-19 in general, but it's particularly true with the Delta variant because it is so infectious. But obviously in an outbreak like this, one has to do the best you can. And I assume that if we ran out of rooms in which to quarantine people who are infected, that would be the next best option.
Yeah. On a related note, one of the things that I think a lot of us have been grappling with is just what sort of vaccination coverage across the population, but also subgroups of the population is required for reopening to the world. And I think the Prime Minister outlined the plan or strategy a couple of weeks ago. That's obviously been overtaken by events. So I suppose the next thing people started thinking about is what is the level of coverage in the community that we need to avoid or limit lockdowns in the future. Now, the government's current strategy is to just go for as many people vaccinated as possible, which of course everyone, or at least not most people, agree with. But I just wonder what work your committee has done on what level of coverage is required in the 12 plus or 16 plus population in order to limit lockdowns into the future.
Yeah, first of all, I can just say I don't think the government strategy has been overtaken by this outbreak. This outbreak was entirely predictable, and as you have noted, we actually predicted it, and it's no comfort to say that, but I've felt like a prophet of doom the last few months. I've kept saying we will have a lockdown sometime this year, it's going to happen, and sure enough it has. But coming back to the question about targets for vaccination, that was something we were directly asked to advise on, and our group had a consensus that it didn't make a lot of sense to pluck a figure out of the air as the Australians have done, like 70% or 80%, because basically the more people are vaccinated, the better, the more options you've got. And it's quite clear from modelling in New Zealand and around the world that with this pesky virus, you don't reach some magical stage of herd immunity where you can just rely on vaccination. So however high the vaccination coverage, we are going to have to take other precautions at the border to make sure we don't have lots of people coming in carrying the virus, and also public health and social measures within the country. And even in Australia, it's clear that even if they get a really high vaccination rate, they're expecting to have to do a lot of things like test, trace, isolate and quarantine.
Could I just add something to David's points, is that also it's not about an absolute number, but it's about what we call heterogeneity in a population, that really the focus should be on what we would call equity here, that you could get a really high number, but if you've got small populations who are under-vaccinated, then your virus will surge within small groups, as we've seen with other vaccine preventable diseases. So the focus is as much on getting high coverage as it is of making sure you don't leave population groups behind.
Look, I 100% understand where you're coming from. I'm not so much asking for a target. I'm asking for what work you've done, if any, with the modelling experts around what the numbers mean. So people talk about high coverage, but there's a big difference between a high coverage of 85 or 90 and a coverage of 70, right? Yep. 85, 90 does different things to your population in terms of the number of people who are hospitalised, the number of people who get sick, the number of people who get COVID. It's just a maths game, right? It's just a simple maths thing. Well, not simple, but it's maths.
No, it's not simple.
No, it's not simple, but fundamentally it's a maths problem. So what I'm asking is what work you've done, if any, in relation to what the numbers mean, because I think what people are struggling with a bit is people say, well, we need high coverage. Okay, that's good. We all accept we need as high as possible, but we also need to have some, I would argue anyway, some work done around what the numbers mean in terms of hospitalisations and sickness, etc.
Yeah, well, unfortunately, there's no simple answer to that because vaccination is only one of the things in the mix. Obviously, we would love to see over 90% vaccination coverage. And as Nikki Turner said, we don't want particular groups to be have less coverage. Otherwise, we'll have outbreaks and they will suffer. But we won't just rely, even at over 90%, we couldn't just rely on the vaccination. So a lot depends on how many people we have coming in carrying the virus. It depends on whether we have to adopt other measures like physical isolation, mask wearing, as most countries around the world are now practicing. It depends on how good our contact tracing is. So it depends on all of us, actually, whether we go and get tested every time we have cold or flu symptoms. So, I'd love to be able to answer your question, but there's no way it can be answered. And that's why we've recommended this phased reopening. We think that the sensible way for us to move once the vaccination rollout is completed is just to start opening the thing in a stepwise way and see what happens.
So maybe if I could add a bit more to David too, you've all by now heard of the magic R0, which is the reproductive number, and all the modelers that we've been working with, and they all work in slightly different ways and use slightly different scenarios and come up with slightly different outcomes. But the focus on all the modelling is to put the different elements that David's referred to into your model to get your reproductive number below 1, which means that one person spreads it to less than one person. Now, there are models out there that we're looking at and we're reviewing regularly, and they're all focused on all the different elements of the puzzle, which are all a moving feast, and I'd be very cautious about using one as the magic answer, but using them as a tool as the situation evolves, depending on the amount of virus in the community, depending on the amount of resources in our public health services and our primary care, they're all within the mix. So it is a bit of a complex model, the harder you look at it.
Just one final question before I move on. This is a really interesting discussion. In relation to your advice that once everyone in New Zealand's had an opportunity to get vaccinated before the end of the year, starting from next year, we could slowly reopen the borders to allow passengers, double vaccinated passengers from low-risk countries to come into New Zealand. What modelling have you done around what that means in terms of COVID coming into New Zealand? The reason I ask that is I think it's reasonably clear if you look at just the maths again, even allowing double vaccinated passengers from low-risk countries to come into New Zealand will mean that COVID turns up in New Zealand because people who are double vaccinated can still carry it and still transmit it. What does the modelling show around how much COVID will come into New Zealand under those scenarios?
Yeah, can I just make a general comment to caution you about putting too much faith in modelling? Modelling is a famous person, it's always attributed to Einstein, but it wasn't Einstein, but a famous person said, all models are wrong, some are useful. And modelling can't actually answer these questions with any confidence. The fact is we're not just talking about people being double vaccinated. Our group has recommended a whole chain of precautions, pre-flight testing, testing at the border. We don't yet know even what kind of test will be used. So that's going to be a crucial factor. You've already mentioned the country they're coming from, and then there are various options available for testing after they've arrived here, or a shortened period in MIQ, or home isolation, and so on. So what we believe is that we should start in the most cautious way and roll it out and monitor very carefully what happens. But although it will be possible to do some sort of modelling exercise, and people may well do that, it actually won't give us a definite answer.
Thank you. Well, thanks, Chris. I've got a sup from David Seymour, and then after that, back to Debbie.
You're muted.
Thank you for that helpful information. Look, great to see you back, Professor Skegg. I just had a question for Nikki Turner off the back of the vaccination discussion. There's a lot of evidence emerging from around the world of vaccine fade. It appears the efficacy of the Pfizer vaccine declines over time, and at least some countries, particularly Israel that started earliest, are experiencing that and starting to talk about booster shots, an actual third shot. I just wonder if you have advised the government, Dr. Turner, about the need for booster shots. And I think it's particularly important because, as we've seen with these vaccines, if the government doesn't get its order in quickly, we can really miss out.
Thank you. Certainly, as a member of the Technical Advisory Group and in my role with the Immunisation Advisory Centre, I'm certainly advising the government on the unfolding story around waning immunity. I think what is written in the public press is a little different from what we are hearing through the scientific literature coming through. And I would particularly caution against the situation in Israel. Many people may not be aware that Israel initially got very high vaccination coverage, but has stalled at around about 60% currently, or something of that order. So still the major problem for Israel and most countries is unvaccinated. So yes, we are starting to see a bit of waning vaccine immunity in those that have been vaccinated for the longest. Most of those are within the severely immunocompromised groups, which are actually very small groups of people. And those people are likely to be the highest need for boosting initially. Now, at this stage within the current New Zealand context right now today, the priority we feel remains to be on vaccinating all the population as quickly as possible with at least one dose. That will reduce significantly the most amount of death, dying and hospitalizations. We will all be watching very closely, and I will assume that in the not too distant future, particularly immunocompromised people first, will likely need a booster. Eventually, probably others, and the data is accumulating rapidly. So we're certainly watching this space really closely. In terms of the government supplies, I think that's a little bit outside my brief.
Yeah, sure. But just to be clear, this is a really big piece of information. You're saying that your advice to government is that vaccine fade is not a real thing outside potentially some immunocompromised groups, and that actually they should be a lot more relaxed about vaccine fade and booster shots than perhaps most of the public narrative suggests.
No, that's not what I'm saying. What I'm saying is you expect with most vaccines, you do get waning immunity over time. The question is when that occurs. What I'm saying is the early data coming through would suggest that some immunocompromised people are those who are likely to see waning immunity first and are the groups we need to focus on first. We do not have an answer yet as to if and when we see waning immunity for the bulk of the population and when boosters will be required. We do not have the science answers for that yet. We're expecting at some stage we will need boosting, but we do not know yet when. The only group we are particularly concerned about in the immediate future are immunocompromised.
Okay, well, Madam Chair, if I could continue with a question to Professor Skegg. Professor Skegg, I'm really pleased to see, and I was thrilled when you were appointed around 4 months ago, and it's really great to hear that you have been completely independent and all your advice is released publicly. But so far, with respect, we've only seen 18 pages, three letters you released to Dr. Verrill. I just wonder, is there more in the pipeline? Should we be expecting more reports from you to be released soon?
Well, thanks, Mr. Seymour. I noticed you made a comment like that in the public arena, and it reminded me of, I think it was Voltaire, who wrote someone a letter, and he apologised at the end of the letter. He said, "I apologise for writing such a long letter. I didn't have time to write a shorter one." We tried to make our reports accessible to people. As I've said, I have briefed ministers in detail, but we've worked very hard. And if people wish our reports were longer, I apologise, but that's the substance of our advice. And we expect to continue to work in the months ahead. It's a rapidly changing situation, and it would not be possible for us to spell out in detail what will happen next year. We may not even be dealing with the Delta variant in a few months' time. 6 months ago, we hadn't heard of the Delta variant.
Okay. Can I just ask about the wider situation that we face, but based on what we know right now? I agree with the comments you've made publicly that just because an outbreak that you predicted would occur has occurred doesn't mean that we should, be alarmed or spooked. But I do wonder if anything in the last 2 weeks has surprised you. For example, it appears that the contact tracing the government's currently capable of is going to take a couple of weeks to get on top of an outbreak under alert level 4 conditions. Now, if that's the case, does that mean that for the foreseeable future, that the only way that we can maintain elimination is by locking down sort of 2 weeks plus at a time?
Well, I wouldn't say we've learnt a lot in the last 2 weeks, except that it's clear that New Zealand does need to strengthen its public health units and its contact tracing capacity. And that was one of the recommendations we made, that there should be a review and probably strengthening of this. And other groups have given the same advice. And I think the huge pressure, I think the people dealing with this outbreak must be working, night and day. It's turning out to be a major challenge. But I don't think it's that in itself has affected our assessment of the feasibility of elimination. But if I said the last 2 months, there has been new evidence that makes us more concerned. And that was particularly the evidence from Guangdong in China just last month, which showed that the Delta variant is not only much more transmissible than the earlier variants of the virus, but also that the period of time from when someone gets exposed to an infected person and then becomes infectious themselves is on average about 2 days shorter. And that makes controlling outbreaks caused by the Delta variant more difficult to control by testing and contact tracing alone. So I think that does make us less optimistic that next year we'll be able to continue the elimination of outbreaks by testing and contact tracing alone. The task has just got harder. The virus has evolved in a way that makes it more difficult to control. And that's just an example,
Look, I have so many questions for you, but I suspect I'll run out of the chair's patience, so maybe I'll get to come back later. I just wondered if I could ask
one last question, David.
A quick question. Just about the incident at Highbrook, where allegedly 5 out of about 700 people were given saline solution instead of Pfizer vaccine. I just wonder, have you been asked for or given any advice about whether those people should have just had serology testing to find out if they were indeed vaccinated? Would that have worked in your view? Were you asked for, or did you give any advice along those lines? And if so, when was that advice given?
Yeah, our group hasn't been asked. In fact, I first heard about it in the media as you did, but Dr. Turner might want to comment.
Yeah, yes, sorry, the questions were for Dr. Turner.
Yeah, my organisation was asked to give advice. I can't tell you exactly what date. We have a string of advice being given. I think in risk, and we certainly recommended informing all the people in the incident. I would have to say in terms of, I'm so sorry. What was the question you asked me? I apologise.
The basic question was that after the Ministry
I'm sorry, David. I've just remembered serology. Yeah, I'm so sorry.
Yes.
I got distracted. The problem with serology is it's not straightforward, and possibly anything up to around 30% of serology tests may be falsely negative, and the positives are hard to interpret anyway. So there's not a simple answer to just doing a serology test on everybody who's been vaccinated to see if they responded to the vaccine. So serology isn't a straightforward answer, and was certainly has been a discussion in our circles over this time.
So just to be clear, you were asked in relation to that Highbrook outbreak if the people should be serology tested and potentially sent back for another vaccination if negative, and your advice is that unfortunately serology testing is not accurate enough to achieve that.
That is only one part of the overall advice that was given, but serology, yes, is inaccurate to give you a full answer alone, and so serology probably doesn't have a key part to play in this. It's a very difficult tool to use and not straightforward.
Based on the advice you've given, what have you advised they do next? If you said there was quite a lot of advice given.
And my understanding is this was with the Ministry of Health, and I think you should take this question up with the Ministry of Health.
Okay, thank you, David. David, just thank you. That's time up, and we'll move on to Debbie.
Fair enough. Thank you, Madam Chair.
Thank you. Okay.
Kia ora, tēnā kōrua. We've got concerns with equity and specifically the under-vaccination of Māori. And although the vax rate numbers are showing as improving and going up, the gap between Māori and the rest of New Zealand has widened. So the stats that we've seen lately is 30.9% Māori have one vax compared to 57.4% of the rest of New Zealand. And proportionally over the last 2 weeks, the gap has widened to 0.4, nearly 0.6% proportionally to the rest of New Zealand. What are your thoughts about the under-vaccination of Māori? More specifically, what is the advice to the government and what does the public health unit need to do to address this?
Kia ora. Just two comments, and I'll ask Nikki Turner to comment as well. But first of all, it is a bit misleading to look at the crude rates of vaccination because they're not adjusted for age. And as you'll know, the Maori population on average is a good deal younger than the non-Maori population. That's partly because of a lower life expectancy, but it's more importantly because Maori people have had a higher birth rate in recent decades. So there are a lot more young Maori people. What I'd heard the Director General say just the last few days, that when you compare age group by age group, the Maori rate is quite similar to the rate in non-Maori, but Nikki Turner might want to comment on that. I certainly haven't heard, and you said that it's actually widening. Do you mean in the last week or two, the gap?
In the last 2 weeks, the stats certainly show that there are more non-Māori than Māori being vaccinated, and in fact the surge vaccination programs aren't landing, in fact aren't narrowing the gap of the unvaccinated Māori.
Yeah. Well, certainly our group have advocated that there should be particular care taken to ensure that the vaccination rollout is done in a way that ensures that there are no groups left out. And that goes for different ethnic groups, such as Maori and Pacifica. It also goes for particular regional subgroups. And one of the points we made, and Nikki Turner's already referred to that R0 figure that everyone's been talking about for the last year or two. It's not just that you don't want groups that have got a lower vaccination coverage. There will be some groups in the community who actually need to have a higher vaccination coverage to achieve the same degree of community protection. And if you take, for example, a group that are in focus right now, Pacifica people living in South Auckland, many of them live in quite crowded housing. They tend to attend events like big church services, and that means that they're actually more at risk of encountering the virus and passing it on than someone like me, for example, who lives in a different social grouping. So it is going to be really critical for all New Zealanders that we take advice from different communities such as iwi and Pacifica and follow their guidance as to how we can most effectively get this vaccine into people.
I think, Nikki, you were going to...
Debbie, just to add to that, I totally support your concerns. I think we have this at every level of our system, deep concerns that we need to be able to deliver and support effectively Māori communities and Pacifica communities in particular, but also lots of other communities like our disability sector as well need to be supported as rapidly and urgently as we can. So all I can say from our end of the sector is that we are putting all efforts we can in to support and hear the voices of Māori, Pacifica communities, disability communities, and those others who feel that they're not being responded to appropriately. Our system needs to continue to review and review and review and look at how we can be as responsive and supportive as we can. This is a systems issue and we must review it on a daily basis. It remains urgent and top priority. So kia ora.
Kia ora. Just to follow up on the equity concerns, was there advice given to the government on a way forward in addressing, and I think you mentioned it as well, David, is the youth profile for us as Māori. I think 31%, and I don't quote me on these stats, by the way, Māori are under 20 and maybe 70-something% of Māori are under 40. So you compare that with the vaccine strategy that's been applied, which was very age-specific. If we've got a young population and this vaccine gap for young Māori, is it then that we can expect that this is a highly vulnerable, and I don't want to put the fear up because we're already sitting in fear enough, but is there a thinking, a strategy, advice given to the Public Health Unit, Ministry of Health on how we target that and that particular vulnerability in this round, the next round, or the other 500 rounds, God say, coming up? Was there a view from your thinking, I guess, is what I'm seeking. And you as well, Nikki, please,
Yeah, well, I think our group hasn't been directly involved, the group that I chair, in advising on the vaccine rollout, but Nikki Turner is on another group that is, so I'll pass this to Nikki.
Great. Thank you.
So I was a member of what's called the IIAG group, the Implementation Advisory Group to the Ministry of Health. I have stood down off that group because I'm also on the Technical Advisory Group and now this one. So, but that group's focus and strong focus and key focus was about the Māori voice and the Māori communities and being heard in the equity gap and alongside the Pacific and the disability. So I would refer you back to the recommendations and advice being put through to the ministry from that group. I think they had a very strong voice, a strongly Māori and Pacific focused. The age issue is a tricky one because as we know, the problem with this virus is that older people die in way, way higher rates and people with medical problems. So that the focus needs to be on that. And we are very aware from our flu vaccination program that elderly Māori miss out and that we've of effort last year into innovative ways in Māori communities for delivering flu vaccination more responsively with Māori communities and did get some success. So I do highlight that, with a lot of effort and focus, we can make a difference. And we actually did a lot better last year with flu vaccination for older Māori people. So I think we have got lessons that we are learning and need to continue to learn.
Thank you. Just one last through the chair. With, on this round, with the modelling that you spoke to that we should or shouldn't take heed of, but actually we do, has there been some advice or consideration on the modelling on the health system's current capacity or required capacity to deal and address equity in large communities or in a large event outbreak?
Well, there hasn't been a lot of modelling done on the capacity of the health system that I'm aware of, and that's something that we have really called for because New Zealand is really vulnerable, quite apart from equity considerations. Just in general, we are not well placed to deal with any substantial outbreak of Covid-19. As you will know, our health system is stretched most of the time, and when one starts to look at things like intensive care beds and so on, we are way below the average for the OECD. So that is one of the incentives for us to try and, it's one of many incentives for us to try and keep COVID-19 as low as possible.
Thanks, Debbie. Okay, across to Aruna Williams and then from there, Dr. Elizabeth Kerry.
Thank you, Liz, and thank you, Drs. Turner and Skegg. My questions are following on from Debbie's concerns about equity, and thank you to my colleagues for indulging me some time, because I do think there is a lot of public interest in getting this right. A couple of weeks ago, the government announced that the time between doses of the COVID-19 vaccine would increase to 6 weeks. From where I'm sitting in South Auckland, that affects a lot of people here who are in those earlier groups, whether they were MIQ workers, but particularly here I'm thinking about Māori and Pacific people. Dr. Skegg, Dr. Turner, can you give some advice to Māori and Pacific people who may have been in, say, group 2 and 3 about whether they should be concerned if they had, say, a 3-week gap?
Well, I'll pass that on to Nikki. I'll just say my ones were 21 days apart, and I'm certainly not, but I'll pass it to Nikki to talk about the evidence.
Yeah, kia ora, David. I was 21 days apart too. So firstly, to reassure people, this vaccine was designed and went through its clinical trials with the 21-day gap, and that's effective. But what the accumulating data is showing, and beginning to show more and more, is that we might get a longer duration of effectiveness if we have a longer gap. So that countries overseas are suggesting, and it's back to the original question about potential for waning immunity, that we will do better with a longer gap. And particularly for younger people who have very strong and vigorous immune response to the first dose, a 6-week gap is very useful. And there is also the potential that the longer gap, they may actually get less vaccine side effects with a longer gap than a shortened gap. So what I want to say is there is nothing wrong with a 3-week gap, but there is a potential gain in having a 6-week gap. Alongside that, the advantage of a 6-week gap is we want to get out there fast and give as many people as possible the first dose. So it's a bit of a trade-off. If we can get as many people as possible the first dose, we do know that 1 dose does reduce severity significantly. So it will reduce severe disease, even if we continue to get transmission. And really, in the end, our priority is, in case we do get community transmission, we want as many people as possible protected against severe disease. So I think overall, with the balancing of all these different scientific issues, the gain in getting 1 dose into people is considerable at this point.
And just on that, so in terms of protection of the partial dose of the first dose, for those, say, 88,000 people who got that done yesterday, can they expect to, not only expect have less impact of the disease on them, but how does that affect the transmissibility if they were spreading that?
Yeah, so it is more effective against severe disease. So the first thing is within a week, 2 weeks, they will have pretty good protection against severe disease. They can still transmit it. It is at lower rates than completely unvaccinated, but obviously we would in the long term prefer 2 doses, which will also reduce transmissibility more. But 1 dose is way better than none, which is our point.
Okay, thank you. Okay, across to Elizabeth Kerry and then Dr. Shane Rutty.
Kia ora. Thank you, tēnā rā korua. I really appreciate your succinct reports. When I read through and I thought, oh, is this the executive summary? And then I realised it was the whole thing. I was so happy. And I like to know what is the guts of it. So kia ora. 2 things I wanted to raise was about advice to government. We, as Māori and Pacifica, we are told constantly, and we are aware of the significant health disparities that we face, and of course in relation to all of the other disparities, which is the natural event of colonisation. When Te Ropu Whakakaupapa Uruta was established as one of the many people who are providing advice, they did actually say that if you wanted to help protect Māori, then the age phasing and applying also to Māori was not a good idea, and they shouldn't do that. So the Minister has confirmed that they decided not to take that advice. I just wonder, is there something in what you've seen and the ways that strategies have pulled out, is there clear evidence that where Māori are in charge of a Māori response for Māori communities, and likewise I'm gathering for Pacifica, that those Māori populations probably do better?
Well, that's I think an important general principle for people, and the more that people can determine their own healthcare, the better. That applies to Māori and Pacifica. It applies to other groups as well. In terms of vaccination policy, there's been a lot of debate around the world as to whether you should focus first on the people who are most at risk of severe complications, and as Nikki Turner said, older people and people with underlying health problems like diabetes, hypertension, obesity are the most at risk. But then if you're wanting just to control the spread of the infection in the community, you might focus more on younger people because they're the ones that are mixing the most. And we're seeing that at the moment with our current outbreak. It's young people who tend to mix the most and may drive an outbreak or an epidemic. And in Australia, the Doherty Institute have actually recommended that they should now focus on younger adults in their vaccination program. I guess as I said already, our group hasn't been involved in the vaccination planning at all. I guess what we want is just to get as many as people vaccinated by the end of the year as possible, and obviously to try and avoid outbreaks like the one we're having. And it won't matter too much who gets it first. What really matters is where we end up.
Thank you.
The only thing I'd add to that, David, is that the system science would say that the best working system is a system that works with its community, communicates well with its community, but is also a high-performing, effective system. So it's all the different bits of the system working well together, which is what could give good and effective and high coverage for any community. Kia ora.
Kia ora. And so that just brings me to my second question, is about your suggestions about improving our public health system. I've been a bit conflicted. I'm totally on board and support what our government is doing. Totally support an elimination strategy. What I've found hard is that all this effort has gone in to make sure people don't die from COVID, but our people are already dying from everything else. And so I've struggled that none of this effort has gone into doing what needs to be done to stop our people dying in all the other areas that we do. And so I suppose if you were going to say what are 2 or 3 things that must happen in our public health system that's going to make it easier to deal with this pandemic, which is not going away apparently anytime soon. Yeah, well, I suppose what are you mentioned it, but don't go into much detail in your letters. What would you suggest?
Well, I guess the most important point is that by controlling COVID-19 and indeed by keeping it out, we've managed to maintain our health system functioning in its normal way, which is quite rare around the world. I mean, in countries like the UK, there's a huge backlog now of people who have had their cancer treatment delayed because of what's happened in the last 18 months. New Zealand's a very rare country because if you look at all the countries in the world and look at their excess mortality over the last year, and that's from all causes, you see quite an interesting rank order. But New Zealand kind of sticks out because we go in the opposite direction. We've had a deficit of mortality in the last 18 months. And that's because not only we had a very small number of deaths from COVID-19, but also because of the way we've been behaving and with the lockdown and the border restrictions and so on, there have been fewer deaths than normal from other causes. So I think it's really important that we do keep COVID-19 under control. But beyond that, you make a really important point. There are many other health problems that New Zealand has. And as David Seymour and others know, I've been rabbiting on about this for years. And, you know, we do have to do a lot about issues like smoking and obesity, which are causing so much poor health in New Zealand. And it's not just a matter of public health, the preventive things, which are obviously my field, but also I believe our whole health system needs more investment. And I think, you know, we see it's under a lot of stress at the moment, even without any significant problems from the pandemic. So, you know, I think as New Zealanders, we have to all accept that we need to invest more in our health system.
Wonderful,
Madam
thank you.
Chair, could I ask a quick sup off that?
Just one sup and then we'll across to Shane Retty.
Yeah, look, Dr. Skegg, Professor Skegg, sorry, Elizabeth Kirikiri's question I think is a good one. You know, people die of other things. It seems to me that just about every society has been prepared to spend a lot more to save a quality adjusted life year from COVID than we have been from other things that harm people, including some of those causes you mentioned that you've championed over the years. I just wonder if you've been asked for or done any work on the cost of COVID measures in terms of quality adjusted life years, vis-a-vis what we're prepared to spend on, say, cancer drugs or road safety improvements or other things where our society frequently has to make that decision.
Yeah, no, we haven't done work on that. But of course, societies react very differently to a problem like COVID that actually closes the whole place down and closes the hospitals down. I mean, we've all seen what happened in the United States, the UK, and so on. So unfortunately, we become quite tolerant of people dying every week from road accidents or lung cancer or anything else because we're used to it. But COVID-19 is an example, and it's true of pandemics and other epidemics of infectious disease. It affects everybody. It affects the economy. It all just grinds to a halt. So it's not surprising that governments pull out all the stops and spend a lot more money all of a sudden because otherwise, everything goes to ruin.
Thanks, David. And across now to Shane Retty, followed by Sarah Pallett.
Thank you, David, Nikki. Good to see you. Thank you for joining us. I'm interested to know, how does the plan you outlined before the current outbreak change with what we now know? Are your assumptions still fundamentally valid? So, for example, day 1 or day 2, there was some modelling expectations, not in your hands, but in others, that we might have 50 to 120 cases, and those assumptions now have clearly failed. So I'm interested to know, with what we know now, what of your recommendations or assumptions change from the plan as you mapped it out?
Well, as I say, I don't think what's happened in this current outbreak has changed our plans at all. And I hate to sound like a terrible skeptic about models, but I think, those estimates in the first day or two, it's very hard for anyone to model an outbreak with such limited data. So I don't blame the modelers at all, but it will take some time to see how long this outbreak takes to stamp out. So I don't think the advice that we gave in our second report has been changed. But as I said to David Seymour, I think the one thing that makes us more cautious is what we've learned in the last, just basically a month ago, from Guangdong in China. And we've seen it played out now in places like New South Wales, over 1,000 new cases today. They've got over 100 people in intensive care. And of course, they acted too slowly. Their lockdown hasn't been as rigorous as ours, but I think we're still seeing something really quite different from what we'd experienced with the earlier variants. So at the moment, I don't see anything which would make us alter the various steps we've suggested, but it certainly makes me feel more cautious.
Thank you. Your reports indicate that, which would seem self-evident, that primary care is critical to the response. How do you respond to officials yesterday telling us that it will take months to onboard primary care, that's GPs and pharmacists?
I think Nikki Turner's probably...
Yes, I can answer that. There are already quite a few primary care and pharmacists onboarding already. So the country's got a mixed model of clinics all around the country between Māori and Pacifica providers, big mass models, and general practice and pharmacy. And you'll be aware, Shane, that there was a delay at the start because of the nature of the Pfizer vaccine, with it having to have the ultra cold temperature storage. So in the early days, we were slow to bring on primary care of that, and it's really been since the updating in the cold chain advice that primary care is getting more experience with being able to manage and take on board this vaccine, and I think we are going to see rapidly more primary care coming on board. I have to say, as a primary care provider, it is still a very difficult vaccine to manage. It's not quite as straightforward as some of our traditional vaccines, so there are some logistical issues particularly for small general practices coming on board, and particularly for small pharmacies coming on board. But we intend and are certainly trying to grow that as rapidly as we can, recognising at the same time that general practices now are also really squeezed with all the other issues going on. So it is a bit of a balancing feat. Certainly we're very supportive of bringing on general practice safely and as effectively and efficiently as we can, and pharmacy as well.
So the mid-safe change to the cold chain regulations were May 28th. That's sort of quite a while ago. I would have thought we could have moved quicker, but I understand that's not a you problem. I'm interested to know, I had colleagues from Canterbury who were concerned clinicians that they received documentation saying they needed to return to work, that they shouldn't complete their administrative, that is their non-patient touching facing tasks remotely from their homes, that they should be returning back to work. Do you believe that's a safe practice?
I'm unaware of this. Sorry, I don't know what Canterbury DHB has been advising. What
would be your view then for our clinicians completing administrative non-patient touching work, being instructed that they should return back to their clinical workplace and work from there under level 4?
Are you saying clinicians who are choosing not to go back face to face?
No, actually, I saw this, Shane, and like you, I was concerned about it. It seemed very odd to me that people were being ordered to go back to work to do things which they could do safely from home. And I would imagine whoever wrote those emails may be regretting them now.
Doesn't quite make sense. Yeah.
It doesn't make sense, does it? My last question would be, David, you've been a strong, I'm sure you have too, Nikki, you've been a strong advocate for Bluetooth technology. We're hearing nothing in this outbreak. Do you have any sense of the role it is playing, and in your view, what role should it play?
Well, as you'll have noticed in our reports, we have been concerned about the very low use of the COVID app in general, quite apart from the Bluetooth technology. And I'm sure everyone on this call will have had the same experience I have. I try and scan in wherever I go, and I'm always seem to be the only person doing it as I walk into a shop or a supermarket. And I think that's been one of our real problems actually in New Zealand, has been complacency. And I guess this outbreak will have shattered that for a time. But that's why we recommended that scanning of QR code should be mandated at some types of venue. And I know it's not a straightforward decision, but the use has been so low. When it comes to the Bluetooth technology, that's of course even lower, the number of people who have that switched on. And so far it's been of very little value because you need both parties to be using it. But that's the kind of thing I think we're going to need to really lift our game on in the months ahead if we're going to be able to be reopening our borders, but also enjoy the kind of life that we have been over the last 18 months. Yeah, I think it needs a lot more work.
Yeah, agree with you. Thank you.
Thank you, Shane. Across to Sarah Pellett and then to Simon Watts.
Thank you, Madam Chair. Thank you, Professor Skegg and Dr. Turner, for being here. It's fascinating. Thank you for sharing and giving us your time. So my question might be directed best to Dr. Turner because it relates to the vaccine, and it's really around our choice to go with Pfizer. Now, I know that we all realised that choosing Pfizer was going to result in us having a rollout that was focused more strongly on the end of year, and we're committed to the whole year rollout. But could you just explain to me a little bit more about the rationale and why we would have made that choice?
Well, I think that, obviously late last year, we made a choice to consider 4 in general with the advanced purchase agreements. Mm-hmm. Now, what we saw from the clinical data coming through last year and the data coming through this year, that Pfizer was a highly performing vaccine. And in fact, the data has just continued to accumulate that it is one of the best performing, if not the best performing vaccine in the world. It's really up there. So I think in terms of clinical scientific evidence, we have got, if not one of the best vaccine in the world. So in terms of offering our population the best we can, the highest protection, that's a really strong reason for going just with Pfizer. Obviously, the supply issues are all about the government and the ministry and how they can secure those. But from my clinical scientific evidence, New Zealand has done us proud by going with the Pfizer vaccine. Now, I think it's a really interesting question looking forward into the future as you look at schedules and vaccine schedules. We discussed about the interval timing, and as the data accumulates, how that might shift. Also, data will continue to accumulate on what might be the best schedule going forward into the future, and there is data accumulating about mixed schedules. Now, that is still pretty early science at this stage. Right now, this year, we've got real scientific confidence that a 2-dose Pfizer vaccine is the best out there on the world market. But, we need to watch this space. We may well be interested in moving forward in other brands as well. There is also a very, very small group of people who cannot take the Pfizer vaccine. So there is a very small group of people in New Zealand who we will need to access another vaccine for, which is likely to be the Janssen later in the year.
Well, thank you for that, because actually my supplementary to that was really with regard to the MedSafe approval of the Janssen and AstraZeneca vaccines. And I just wondered if you could expand a little bit more about the factors that we might take into account if we are considering whether to include them in our vaccination programs.
Yeah, so there is a very small group of people who have a contraindication to the Pfizer that is essentially people who have had a severe allergic reaction, anaphylaxis to the first dose of Pfizer. Those are the people that we would not recommend a second Pfizer to. So there's an advantage in having a small supply of a different alternative, safe, effective vaccine. Both Janssen and the AstraZeneca have been approved by MedSafe, so that's the role. Going forward into the future, if and when we look at boosters, then there's a role to look at the different mix and match we have amongst the vaccines and what would be the most effective for New Zealand. So this is, ongoing science, and I'm happy to have this conversation as we learn it over the next few months.
Certainly evolving. Listen, thank you very much.
Thank you. Across to Simon Watson, then David Seymour.
Yeah, thanks very much. Look, question for Professor Skegg, and I've got two. Look, the official guidance for the current lockdown in Auckland is obviously a time frame until next Tuesday. Based on current trend numbers, when do you foresee a meaningful easing of restrictions?
Well, I said that, I'm not able to talk about the current outbreak with any great wisdom because I don't have any information that you don't have, but as an uninformed person, I would say it's most unlikely the lockdown will end next Tuesday. It's clearly going to be a matter of some weeks, I fear.
Okay, and the second one is you noted in your opening remarks that this outbreak was predictable. So do you think that we were adequately prepared? And if not, what areas could we have done better in retrospect?
Yeah, first of all, the reason I think it was predictable is that no system is perfect. And people kept saying to me, oh, well, we haven't got COVID. We have had COVID. We've had Delta in the country for weeks, if not months. We've had it in at least 3 hospitals. We've had it at MIQ facilities. Sooner or later, however hard you try to have a perfect system, things go wrong. So it was inevitable that Delta would come into the country. I do believe the government was preparing for this. Every second Tuesday, as chair of this committee, I get invited to sit in on the first part of a meeting of the heads of all the government departments and ministries that is chaired by the head of DPMC, Brooke Barrington. And they have been talking for a long time about preparing for a Delta outbreak. So it didn't come out of the blue. It wasn't as if they weren't expecting it. So I think there was a lot of preparation done. But was everything done that could have been? Well, of course not. It's like everything. If we have an earthquake tonight, my household won't be as well prepared as I'd like to be. This was a predictable event. And, I'm sure that when it's all over, people will look back and think, and I hope we'll learn from the experience about things like our contact tracing capacity. But I do think that it was expected. Obviously, people hoped it wouldn't happen, but it has.
So based on what we talked about before around vaccination levels, you mentioned around 90%, but the reality is high as possible. And I think the press have reported today, December is sort of the timeline. Is the reality is that we should expect sort of the deployment of lockdowns until we get to that point where our vaccination levels are at that level of appropriateness? Would that be reasonable?
Yes, if we have an outbreak, if we have another outbreak of the Delta variant in the coming months, I think it's inevitable that we would have another lockdown. Obviously, I hope we won't. We have gone for just under 6 months without a single outbreak. Obviously, I hope that this one is stamped out quite quickly and that's the last one we have, but only time will tell.
Okay, and just the last question, Professor Skegg. Look, I'm interested in your views on how our elimination strategy can be pursued long term. You mentioned at the start, we'll review at the start of next year, but can you give us a little bit of, what planning have you done for that next phase?
Yeah, we've had a lot of discussion about this, but again, I have to emphasise it's very hard to plan 6 months ahead with this virus. I'm actually on an International Science Council panel with Peter Gluckman, and we're looking at, it's a group of people from all over the world, looking at future scenarios for the COVID-19 pandemic. And there's so much uncertainty as to how this pandemic is going to evolve. And there's a very distinguished scientist from South Africa who made a comment at one of our Zoom meetings. He said, a year with another disease is a month with COVID-19. In other words, it's changing so quickly. So, I'm sure that we will need to revise our strategy, whether it's still called an elimination strategy. By the way, our group don't like that word. We actually recommended that there should be a different name for New Zealand's approach to dealing with COVID-19. No one's shown any interest in that recommendation, but it's just an example of how, we don't think elimination is a very good word. It confuses people. It doesn't mean eradication. But I'm sure that the strategy will have to be revised, but that can only really be done closer to the time when we know what variants we're dealing with, when we know more about the issues about the vaccine, some of which have been brought up this afternoon about, for example, waning of immunity, the extent to which the vaccines prevent transmission of infection as opposed to preventing severe admission and death, for which we know they're extremely good. And we'll have new tests. We may even have antiviral treatment on the horizon, and that could really change our approach to this disease. And also, I hope that in the future we may have better vaccines. The vaccines are fantastic, but it would be even better if we had vaccines that reliably prevented people from passing the infection on to others. So, it's a kind of question of watch this space. I'm sorry to appear to be ducking your question, but I think it would be really quite silly for me to say what we're likely to be doing in that space next year.
Thank you, Professor.
Thank you, Simon. Across to David Seymour and then Chris Bishop.
Well, look, thank you very much, Madam Chair. Professor Skegg, I just wondered if I could ask about the idea of the vaccine rollout being completed. It's throughout your letters, and it seems to me that your basic strategy is to complete the vaccine rollout, then other things become possible. But I just wonder if you could define what completing the vaccine rollout means. You're reluctant to give a specific percentage. So how will we be able to tell if the vaccine rollout is completed?
Well, we chose those words deliberately because we weren't thinking about a particular percentage. If you wanted one, I'd give you 100%. But
well, you also say that's unrealistic. So.
Yeah, unfortunately. But it was really a logistical criterion that everyone has had a chance to be vaccinated. Obviously, we hope that a very high proportion of people will take up the vaccine. And by the way, no one would have wished to have this outbreak, but I think it will have reminded people that this is an ever-present threat. So I hope it will increase the vaccine uptake. But what we were thinking was, our group only gives advice about the health aspects of this pandemic, based on the scientific evidence. We accept that the government is going to have to consider all the other considerations, social, economic, and so on. If you asked us, what's the safest thing we could do for New Zealand's health, I would say keep the borders completely closed. I mean, that if health was our only criterion, that's what we would do. I know you won't have arguments about the effects on the economy and therefore on health and so on, but we are assuming that New Zealand is going to reopen. We cannot stay cut off from the world indefinitely. So we are acting on the assumption that once everyone has had a chance to be vaccinated, the government is going to start reopening the border in a staged way. And I think there would be, I imagine, a political consensus about that.
So can we take from that what you're really saying is complete the vaccination program means everyone who wants one's had an opportunity and had one?
Yes. Of course, there is the issue about the lower age bound, which is under discussion at the moment.
Sure. Can I just ask? I'm sorry. Were you still going?
No.
Can I ask a supplementary on that, David?
Yeah, of course. Go, Chris.
Because I was going to be that follows on from what I was going to ask anyway, which is it's a really interesting question, or really interesting comment, Professor, around you're assuming that we will reopen. I suppose the question is this, and this is what I've been grappling with over the last month or so, or last 2 weeks in particular. Say everyone gets offered the chance to have a vaccine by the end of the year, and we get to December 31st, and 68% of people 12 plus have been doubly vaccinated. Would you still advise the government to proceed with partial reopening of the borders as they've outlined in the first quarter of next year?
Well, as they say, that's a hypothetical question because I'd be very disappointed if it's only 68%.
But the reason I ask that is that is a realistic possibility. That's why the numbers matter.
Well, they do, but you see, we don't decide. I mean, we advise on what precautions need to be taken. It is not up to our committee to say whether the borders should be open or not. What we are urging our fellow New Zealanders, please get vaccinated for your own sake and for the sake of your family and your whānau and your community. At the end of the day, it's the New Zealand public who will make that decision, Chris. They will decide whether they get vaccinated and they will decide politically whether they want to open the borders. No doubt your party and every party will be polling people to find out whether they want the borders open. It won't depend on us.
I appreciate that, but that unfortunately, or this is just the reality, your 3 letters to Dr. Verrill have been linked in the public consciousness and in fact by the government, to be honest, to the reopening of New Zealand and the loosening at the border. And it was, the letters were released a day before the reopening to the World Symposium, which you spoke at. And paragraph 12 of your last letter says, our expectation is that with all the precautions outlined in our previous letter, the scheme would lead to relatively few incursions of the virus and that these could be stamped out quickly. Now that reads to me like basically a form of advice to the government around how to reopen safely. So my question is really, is it safe to reopen as outlined by the government with only a 68 or 69 or 70% vaccination coverage?
Well, when we wrote that letter, we assumed that we would achieve a considerably higher coverage than that. But let me be completely frank. When we reopen the border, things are going to get tough. I keep saying to my friends, this is the golden year. We've had a wonderful time. The last 6 months, we're almost the only country on earth just living a normal life. I know some people have been really impacted by the border closures, obviously families that, can't be reunited, but people who work in tourism, I know some of these people and they're suffering. But most New Zealanders have been able to enjoy normal social life. Our economy is doing well. I think this is, many people sort of say, oh, what we've been through, we've spent less time in lockdown than countries. But I think things will get more difficult. When we start reopening the borders, we're going to have outbreaks of COVID-19 and they may be difficult to control. And we obviously want to avoid having lockdowns. So I think we all need to be aware of that this virus is not going away, and unfortunately, we're going to be in a war with this virus for years.
Can I just come back in? Oh, sorry.
That's fine. Come back to your, because it was a sup. So David, back to you.
Yeah, well, you're very generous here. Look, I just wondered about that following on. Do you believe that what other countries do is important in New Zealand's decision making? Because I see the Prime Minister of Australia being quite aggressive about the abandonment of elimination, even saying New Zealand's living in a cave. I mean, it seems to me we could end up with, China, a country that we have some things in common with, but some very stark differences with, and New Zealand being almost the only remaining elimination countries. And you said in your presentation, our problem is we've been abandoned by our allies. But to what extent do we have to have different strategies or scenarios depending on what other countries do, particularly Australia?
Yeah, well, that's a really good point. Thank you. Yes, I did say our allies have let us down, by which I meant the rest of the world, really. And the independent panel chaired by Helen Clark really highlighted how the World Health Organization didn't provide the leadership needed. The human family could have done so much better with this pandemic, 18 months ago. And it does make it much more difficult for us. The ideas we had about an expanding bubble with Australia and more countries just are no longer realistic. But going back to the comment you made about Australia in particular, which obviously is our closest neighbour and our most important ally, I thought the comments from Scott Morrison were pretty inappropriate, but very much stated in his own political context. And by the way, Mr. Morrison has never supported elimination. It was the state premiers who actually ensured that Australia did eliminate COVID-19. But I've got somewhere here, I
should add, he is an Australian too.
Yeah, well, he is. And my general reaction when I heard his comments about us living in a cave, I thought, well, I know we were involved in the negotiations for federation in 1901, but we decided not to become part of the Commonwealth of Australia. And at least that means we can choose our own destiny. And maybe some of the other states like Queensland, South Australia, Western Australia and Tasmania are having the same thoughts at the moment. But right back in July 2020, he said it was impossible to achieve elimination, which obviously wasn't true, and that trying to eliminate the virus was not the right strategy for Australia. And I've watched Mr. Morrison's press conferences over the months. And one thing I find really interesting, and when New Zealand's doing better than Australia, which has been a lot of the time, we may as well not exist. He never mentions New Zealand. In fact, he says no other country has done as well as Australia. But the minute we have a setback like this, we suddenly come into the conversation. But I think he is clearly facing a big internal problem that he's got his national plan, but the premiers of several states have made it clear that they no longer want to follow that plan. And one of the problems is that it's already been scuppered by what's happening in New South Wales. And so I think it's going to be very interesting to watch what happens in Australia. It may even be quite a constitutional issue because you've got different states, who maintain their own borders, really going against the idea that the whole country will live with COVID.
Yeah, well, he's not the
David,
only
can
one.
I just
David,
interrupt? Sorry. Do you mind if I just go back to Chris's question, which is a valid question, is
Sure.
we don't know what we're going to end up with in terms of immunisation coverage. We hope, we have confidence it'll be high, but we don't know. We'll do the best we can in the country. And really, with all the best modelling and all the best international knowledge in the world, we are just going to have to take it step by step. And the recommendation from our committee is to carefully open up in little steps at a time and see how our services cope, whether we can track and trace and stamp it out or not. So, Chris, we can't give you a clear answer, but I think it's really important that we don't just lock, stock and barrel open up, but that we watch, do a continuous quality cycle. We open up step by step and then see how our services respond and then make our response in relation to that. And it's a really graduated approach. It's not, a clear, straightforward pathway, but it's a step-by-step graduated approach, because we will not know, and you're quite correct, the absolute level of immunisation coverage we'll start from, nor will we know whether we can get homogeneity across all the community, and we've still got communities at high risk. So, some of this will remain unknown as we move forward.
Yeah. Can I just
Thank you, Nikki. David, we're just in the interest of time. I'll hand over now to Chris Bishop to complete his primary. Thank you.
Yeah, thank you. And it follows on from David's point, I think. And thank you, Dr. Turner. I suppose the problem that we face is that there's a disjunct between what you just said and what's kind of been outlined by the government, which is, but anyway, I won't get into that. But I suppose the ultimate question for both of you is, what would it take in terms of New Zealand's, in terms of something happening in New Zealand, for you to conclude that elimination is now an impossible goal? I'm not saying it is, but what would it, I know it's a hypothetical question, but what would you be looking for you to conclude as an expert group that elimination had now moved beyond being possible into being impossible?
Well, as Nikki Turner just explained, we will be trying to do it. We've emphasised that the way the term has been used in New Zealand, really since early in the pandemic, is that elimination does not necessarily mean zero COVID. It means zero tolerance for cases of COVID, so stamping it out. We will continue to try to stamp it out. When we fail, we've emphasised, and I said publicly on the 12th of August, we may fail. We're taking an ambitious strategy, but we lose nothing by doing that. In fact, it keeps our options open. But we may find that it's not possible. We may find we have to move to a suppression strategy, but it won't be something we won't think in advance, let's give up and let's stop trying to live the way we are. It'll just happen if it does happen. And but unfortunately, it will not be good, because we will all have to live a more restricted life. People will have to shield from each other, particularly older people in winter. Yeah. We'll probably all have to wear masks. And a lot of people will get sick and die, and not just from COVID, but also from other diseases which won't get treated in a timely way because our health system will be so overwhelmed. So what we're saying is, let's do our best. Unfortunately, the Delta variant makes things more difficult. But if we can achieve a really high vaccination coverage, we still believe we've got a good chance of pulling it off.
Yeah. Chris, can I just ask a quick question?
I add a little bit more to that.
Yeah.
Sorry,
back to Nikki and then to Chris. Yep.
Thanks. I think there's a bit of a misunderstanding about the concept of herd immunity, that a virus never ever spreads in a community, but what you can get is degrees of herd immunity, and this is a realistic option going forward, is that we do get the virus into our community, we track and trace and stamp it out as much as we can, but you still have a degree of community spread. Now, we don't know what that will look like in New Zealand, but that is a realistic option going forward, that it will continue to spread in the community, and our public health services will adapt to the degree at which they could. We may not manage to stamp it out, but we may manage to control it in different ways, which is the next step away. And that's what we'll have to watch closely.
I understand what you're saying. I understand what you're saying. I suppose I just make the comment that is going to be a massive psychological change for the New Zealand population. New Zealanders have become very persuaded by the idea that one case in the community is Disasterville. I just make that point that it's going to take quite a cultural, psychological change in our population. I'd have a couple of smaller points. Do you have any estimated effective R value for Delta during this current lockdown? Have you done any work on that?
We haven't seen the data on the current lockdown. But can I just comment on your previous statement? At the moment, one case of COVID is, was it Disasterville you said? I mean, we've seen what's happened. In fact, our current outbreak all goes back to that one limousine driver in Sydney who was infected while he was transporting, aircrew. And the whole Sydney outbreak, it's spilt over into Victoria, Queensland, ACT, and now New Zealand. It all comes from that one case. But of course, if we have a really high vaccination coverage, the scenario is quite different.
If we do. Yeah,
Could I just reflect one more issue, that it is challenging for our country to live with uncertainty, and that we make the best strategy of the day, and it's challenging for all of us to know we need to continue to live with the uncertainty around this. And I really reflect what you're saying, that, you know, it is hard for our people.
Yeah.
That's something I wonder if I could ask a quick sup off, Chris.
Just making sure, Chris, have you finished your primary line first?
Oh, I've got one more question for Dr. Turner, but I'm happy for David to ask us up.
Oh,
Okay.
no, well, you ask your one first. That'll keep.
Okay. Well, just very quickly on Dr. Turner, it goes back to the Highbrook stuff, which is in relation to the Vaccine Technical Advisory Group. Was your committee made aware of the incident in Christchurch as well, or similar incident?
I was referring to advice that was asked to the Immunisation Advisory Centre, not the Technical Advisory Group.
Oh,
So this is a different capacity in terms of reference. Okay, across to David.
Yeah.
Yeah.
But
No,
yes.
well, no, I still want the question answered.
Well, I think that the problem
I
is...
said yes, sorry, but through INAC, not through the Technical Advisory Group, through the Immunisation Advisory Centre.
In relation to the Christchurch case as well as the Highbrook one?
Yes, that's correct.
Okay.
Okay, thank you. Across to David.
Yeah, just picking up on something Dr. Turner said that I think is really important, and if I could reflect something that a lot of people I represent have expressed in different ways. Certainty is really important for a bunch of personal and commercial reasons. Now, we understand that there are real physical problems, evolving variants, not sure about vaccine uptake, but I think what would be so helpful is if you were able to lay out, you know, alternative scenarios so that people can have a glimpse of what the future might be like given some of that uncertainty. Because, you know, while I respect the work you're doing and the challenges you face, to say that, you know, we can't plan anything in 6 months, anything could change, we just don't know, you know, it doesn't deliver the certainty that people would really crave from you.
Yeah, well,
I think that's very useful feedback, and I think we could take that back. Sorry, David, over to you.
Well, I was going to say, I mean, we have spelt out the steps we think should be followed in the first part of next year. But I would just say there's one thing more important than certainty, and that's honesty. And unfortunately, we do have to live with uncertainty. We all have to do it all the time, of course. I mean, no one knows whether they're going to live for many years or whether they'll die tonight. But this is a particular situation which is so dynamic. And I mean, who would have imagined that Sydney was in the situation it was, you know, 2 months ago or 3 or 4 months ago? No one would have imagined that they've been in lockdown now for 2 months. It's going to go on for weeks or months ahead. So it's a very difficult, and I think we've really got to explain to people why we have to live with uncertainty with this pandemic. But we have tried to spell out in some detail what steps we should be taking next year.
Yeah, but if you look at the Sydney example, I mean, your own report forecast, and I don't think it was particularly difficult to forecast, but you said it, that the Delta outbreak in Auckland would occur. You could have made the same forecast for Sydney. It's just a bigger version of Auckland, one step up the global supply chain. You know, there are things that you can say.
Yeah. Well, as
I think there's a difference between being certain about an outcome and what you're suggesting, I think, which is saying these are some other possible outcomes. And I think that's reasonable, and we're certainly looking at that, at what the possible stages would be. But you've seen in other countries where they come out with certainty, and they're certainly proved wrong in their certainty. So it is a difference.
Yeah, and that's why you need
Thank
to
you for
lay
that.
out
And so,
all the
David,
detail.
we will just move on now because that was a sup, but just moving on to Anai, a question from you, Anai.
Thank you, Professor and Dr. Turner. Just wanted to go back to, I know what we're seeing overseas and how Delta has entered our community. My question is about if you can just tell us how keeping this more infectious variant out for so long as we did has helped us respond effectively to it.
Well, it's obviously had hugely beneficial effects on our way of life and our economy, but it's almost been a problem, I think, because it has made us complacent. I think a lot of people felt we've beaten this virus, when of course we hadn't. We were just keeping it out. So, and I think, you know, that it was really necessary for people to realise that this is going to be a more difficult challenge in the time ahead. I'm not sure if I understood your question, but...
No, that's okay.
Yeah.
Can I just follow up on that as well? Just on the threat posed by new variants in general, what are the perfect conditions or the environment for these new variants to emerge, and whether there's anything that we can do to prevent or prepare for these for an issue like that?
Yeah, well, that's a really big global challenge, because the more replication, there's millions of replications of this virus going on, and mutations occur all the time. And if there will be new variants, and if there's one that's more easily transmitted than Delta, it will become dominant over time. And it's completely unpredictable. And actually, Peter Gluckman and I have had interviews with some of the leading evolutionary virologists, and they make it very clear that you can't assume that the virus will become more or less lethal. Some people have this idea, oh, well, it's bound to become over time more like the common cold and so on. That really is not the case. The next variant will be more transmissible. That's how it will displace Delta. But it may be more or less harmful to humans. And obviously the worst case scenario is one that is more virulent, causes more severe illness and death, and particularly if there were one that was able to evade the vaccines. Now there's no, there are already one or two variants that are more resistant to certain vaccines, fortunately not the Pfizer vaccine. But obviously the biggest concern would be if a variant were to become prevalent that was able to evade the vaccine-induced immunity. And that's just another example of the kind of thing that could happen before the beginning of next year, and would certainly make us think very differently about opening the border.
And if I could just back David up, I think a lot of people misunderstand that the reason that viruses mutate is lack of immunity so they can spread. The more world immunity there is, the less the virus will spread, the less mutations we will see. This virus is actually more stable than flu viruses, so we're not expecting it ongoing forever to constantly mutate. If we get a degree of immunity throughout the world, which will be a mixture of people being exposed to the disease and vaccination, then we are hoping to see less mutations. And that's the, a key international message for all of us. And once again, a strong message behind immunisation that it will reduce the risk of further mutations.
So thanks, Nikki. Hey, we're really nearly at time. We've just got one final short question from Simon Watts.
Yeah, thank you very much. Look, our New Zealand health workforce have done an absolutely terrific job to date in terms of doing what they can do to support this COVID outbreak. I guess, Professor Skegg, if there was one thing from a government policy point of view around the health workforce that we need to be working on urgently, what would you see that being to prepare us for next year, saying that you said, it's potentially going to get a lot more bumpier than what it's been this year?
Yes, well, I think the most important thing is to really support the formation of the workforce. I mean, we obviously have a shortage of nurses, for example. And it's only a few years ago, I remember, because one of my daughters is a nurse, people graduating from nursing school couldn't get jobs in the local DHB because they prefer to get people from overseas who are more experienced. So we've really got to focus on training our own people. So I think, it's really important that workforce planning and supporting our health workers because clearly there's a world shortage and we need to look after our own people.
So thank you. And Nikki, did you want to have a final comment on that before we finish?
No, I absolutely support it. The other thing is, we are trying very hard to diversify our workforce. You'll all be aware that last week the problems with the Delta arrival is that our one workforce is pushed between needing to swab and to vaccinate. So we're under a lot of pressure, and thank you for the comments about supporting them. There's a lot of people out there working really long hours at the moment. We are also working towards trying to diversify it and trying to take away as many of the traditional blocks as we can to make it as easy as possible for everyone. So we really appreciate your support on that, and we appreciate the support that the health workforce is doing its best, and we want to get out there and really support safe vaccinating rapidly as we can while we're swabbing loads of people.
Okay, well, thank you very much. And thank you to both Professor Skegg and Dr. Turner. It's been a really informative session. And that's us for the final session of the Health Committee for this week. So thanks for tuning in.
Thank you. Kia ora tātou.